The previous session was clinical skills teaching, now the session is clinical skills assessment. It has two parts. First part I will take, second part Dr. Puri will take. So this session has objective. I'll just touch upon what is the difference between assessment and evaluation. What are the current methods, limitations of them, newer methods, what is workplace-based assessment, and this is given a lot of emphasis in CBME, and what is Mini-CEX and DOPS or DOPS. So if you look at so this is where we are going to focus on. If you look at the objectives at the end of this session, the idea is that each one of you will be able to describe the advantages and disadvantages of conventional and newer methods. You will know a bit about Mini-CEX, intro, advantages, disadvantages and technique, and similar about DOPS. So these are the two things that the session mainly will revolve around. Assessment and evaluation. Can anybody tell me what is the difference between the two? Even when I came to know, I was, before around 3-4 months, I was like, now finally it is clear what's the difference. Anybody? Sorry? Feedback is a component of assessment. No, but summative assessment, there is no feedback. Marks. Then it is evaluation.
If you are guiding him or her for his mistakes, that is an assessment.
Anybody?
When you observe something and divide up in fractions and give them the scoring marks or whatever it is mostly related to assessment. It can be teacher to student or it can be from the patient also, doctor to patient also. And evaluation is when you have formatted something and then you go for the marking system. And then you finally say you pass or fail.
Correct, but I think in the context of CBME, they are very different from each other. And if you look at assessment, it relates to performance of a specific task, which is everybody knows. But fundamentally, you are assessing a student. So if you're talking about a student, there is assessment. Okay? So far? Good. An action, formal or informal, to gather information about a student. But then what is evaluation? So in the evaluation, we are passing a value judgment about the program. So you can subject a student to assessment, but you can subject a program to evaluation. Okay? So you can evaluate a program and you can assess a student. Now, the various aspects in which you will evaluate a program, one of them will of course be the assessment of students. Part of it, right? But then there are other aspects of the program. So just because I took a lecture, I decide that I'm going to take a lecture every single day, 3 to 4 p.m. for one full year for all undergrads. It does not mean that I elevated the level of surgical teaching in the department. No. That educational program or endeavor that I did needs to be evaluated, and that has different methods. Just because the student scored well does not mean that it was because of me. Okay? So it is used in terms of educational programs. It is usually used, evaluate graduate courses. So you evaluate educational programs, evaluate graduate courses. It has a very broad meaning, and that's why it has multi-source input. It's not just one single number or one single aspect. What are the current methods? We all know current methods of assessment: long case, 2 hours, 3 hours, case presentation, seminars which go on for 1.5 hours, 2 hours, 3 hours, right? So what are the current methods? Current methods are also a task that mimics professional life. આપણે એવો try કરીએ કે long case છે તે એવું patient એને આવશે, right? So consider we taking there's a medicine case presentation of maybe valvular heart disease, and of course he's going to meet him. So that is okay. So in a way we are trying to mimic a professional life. It is observed by the examiner. Finally the learner is questioned. So this procedure does provide a lot of flexibility, but at the same time it provides a lot of objectivity. If I am taking a case, then somewhere in the middle, if I wish to deviate, then I can. a lot of times we all have seen that the case started with abdomen and ends with locomotor. Okay, a case of cardiac ends up being that of neurology. Right, and then we say, you were driving the car, you took me there, તારે સાચો જવાબ આપવો હતો ને તો મેં તને હું તને એમ તેમ ના લઈ ગયો હોત પણ હવે તે પૂછ્યું then I asked you. So the usuals are long case, short case, and table. A long case is, detail of a single case. The limitations are, of course, that we cannot, you cannot judge about a particular student based on just one case presentation. So long cases are, flawly, or rather we can say that erroneously given such a huge importance in our current assessment systems, and like completely flawed. Short cases are even slightly better because you can have more short cases. It can cut across various specialities. It can be for various systems. It can be taken by various assessors. So that is why it has slightly more validity. And tables are, as we know, instruments and Excel. And here also there is a lot of subjectivity. Sometimes when the table starts and if the examiner decides that I have X-ray पूछवा है, so from morning till evening he's asking the same, and most likely that is why the students who are yet waiting for their turn, they just ask them, "Visu पूछा है साइड में खाली कही दे तो मारो काम पूरा है." In fact, by around 3 p.m. we all have examined students and we know what's all condition. So these are the limitations of current methods: that inefficient standardization of patients, less objectivity, less validity, and less reliability. I think attributes of assessment were taken, and there are 5 attributes of any assessment. So they are validity, reliability, feasibility, acceptability, and educational impact. So out of the validity and reliability are most important. Validity is that how effectively it assesses what it should assess. Okay, so more of કે ભાઈ આ એક્ઝામ પછી મને એની ખબર પડી જોઈએ કે આ છોકરાને હર્નિયાનું એક્ઝામિનેશન આવડશે, right? So is that method of assessment doing that or not? And reliability is how reliable it is in various institutions, in various departments, or at various times. So the same, it also means reproducibility. So if these are the limitations of current methods, then what are the newer methods and why did we have them? So CBME, CBME competency based medical education, whatever you've been learning for the last 2-3 days, you learned about teaching and then you learned a bit about assessment. So assessment can be that of knowledge or can be that of skill. This session is about skills assessment. Now skills assessment can be done at workplace or it can be done at other simulations. So what is workplace based assessment? Exactly. Funda is there is a real patient involved. In the process, there is a real patient involved. It has higher stake, right? In simulations, there are no real patients. So workplace-based assessment can be that of clinical skills or it can be that of procedural skills. The clinical skills, workplace-based assessment is the common thing is Mini-CEX. Procedural is DOPS, so these two I am going to take, and the simulation is OSCE and OSCE. So these two I am going to take. This is what Dr. Puri meant. So now, considering that newer methods came up, there is a bewildering number of acronyms that are floating around the scenario of medical education. Of various methods have been devised. So there are things like acute care assessment tool, case-based discussion, which we talked about, DOPS, which we will, multiple consultant report. As Nilima rightly said, that when Chetna madam said something about sir, we gave it heavy weighting. So that is how multiple consultant report, people's subjective opinion or assessment about a particular student. Then there are multi-source feedback, also known as MSF or 360-degree feedback. Outpatient care assessment, Mini-CEX, OSCE and OSCE. If you look at clinical skills assessment, their workplace-based assessment, there are mainly 3 broad categories. So whatever you say, they ultimately will fall in one of these 3 categories. The first category is things that are observed. So whether we are looking at Mini-CEX or we are looking at OSCE or OSCE, basically we are observing someone perform. Okay. So that is why these are observation-based method. Another is chart-stimulated recall or case-based discussion, where there is no patient, real patient now, right? There is nobody else. There is just the teacher, the case paper, and the student. Right? It is usually summative. Why it is summative is because all the actions have already been taken. આપણે એ નથી પૂછવાનું કે તું હરિયાનો પેશન્ટ આવ્યું આનામાં તું શું કરીશ. We are just going to ask them કે તે પેલા પેશન્ટમાં ઇન્વેસ્ટિગેશન કરાઈ હતી આ કેસ પ્રમાણે. So why did you do it? So that is known as case-based discussion. Or third thing is MSF or multi-source feedback, also known as 360-degree feedback, which is where you ask the peers, you ask the staff nurse, you ask the orderly, you ask other consultant, you ask the friend, you ask the patient, you ask the relative. તમને આ માણસ વિશે શું લાગે છે? So that is how it is 360-degree assessment. So workplace-based assessment is interaction between the patient and a member of healthcare team. That is already very routine for us, and that is why it makes more sense. And skilled clinician educator can efficiently judge, and he can also provide feedback. It most reliably mimics the actual professional life. Again, we come back to Miller's pyramid. We have often, so the basic is knows how, shows and does. So this is knowledge, competence, performance, and action. So if you look at Miller's pyramid in the original, speech that he gave, 1990 my speech article. So in that he said that if you want to differentiate between these two, so if you have a competency for which the Miller's pyramid level does, then you need to assess it by workplace-based methods. And if you have competency where shows is enough, so then you can go in simulated method. So clinical skills assessment is based on what is the level of the competency on Miller's pyramid. If it is does, then you have to go in real life scenario, real patient. If it is just performed, then it can be managed with simulation or OSCEs. So basically you should assess the appropriate level on Miller's pyramid and Bloom's taxonomy. Be aware of the factors that can influence validity, and finally consider alternative complementary methods. When you see various assessment methods, some have higher validity and lower feasibility. Some have higher feasibility but lower reliability. So that is how you can actually complement some of them in order to ensure that your ultimate outcome is achieved. Now we'll look at Mini-CEX and DOPS. I just want to, I have given the bunch of papers on your table, 7 each. One of them is Mini-CEX form and one of them is DOPS form. I just want you to keep them with you. Just distribute 7 each. Just okay, no worries. I mean, there's nothing to be written on them. So it is. I'm already going to display them on here. But okay, so 2 each. One is for Mini-CEX, one is for DOPS. Okay? Yeah. So Mini-CEX stands for Mini-CEX stands for Mini Clinical Evaluation Exercise. Okay? CEX stands for, or traditional CEX stands for, of course, Clinical Evaluation Exercise, which loosely translates into our long case. Okay? So CEX can loosely translate into our long case, which can last for 1 hour, 1.5 hours, or 2 hours. Basically, Mini-CEX was sort of invented or created by American Physician of Internal Medicine, American Board for Internal Medicine, ABI. So Mini-CEX stands for Mini Clinical Evaluation Exercise. It's a modification of traditional bedside oral examination. Student meets a series of real patients. Series means for one encounter there will be one patient, but one Mini-CEX is not enough. So you always need to do it more number of times. Then skilled clinical educator judge and provide feedback and takes about 10 to 20 minutes. This is an observation model. Okay, so the encounter between the student and the patient is happening in front of the teacher. So when you go and you can ask the student, to हमने history and examination कर, and you will just you have a checklist which we'll go through, but then you are observing what is happening. and in the end you are going to provide feedback. So there are six skills which are technically assessed in this: medical interviewing, physical exam. So history taking and physical exam, two very basic skills. Then professionalism, clinical judgment. Did he reach the correct diagnosis, or rather was bordering around the same? For counseling skills, organization efficiency, and finally overall clinical competence. So this is a total score, but these are the 6 skills. How do you rate them? So the rating scale is 9-point rating scale. So from point 1 through 3 is unsatisfactory performance, 4 through 6 is satisfactory, and 7 through 9 is superior performance. The strengths are that it tests trainees' performance with real patients. The assessor is a clinical educator, so he can also judge and provide feedback. Okay, so this can be used as a formative assessment tool, because at the end you are providing feedback. You are assessing, you are putting a value judgment on the student, but at the same time you are also pointing in that what next needs to be done. And the trainees are presented with complete and realistic patients. So it is not like one patient may have abdominal pain for that, but he also would have diabetes mellitus. So he cannot have an isolated theory lecture around abdominal pain or diabetes mellitus. He has to think in that context. So they are actually meeting real patients and complete and realistic clinical challenge, and hence they will have to put all of their faculties to use. The weaknesses are single encounter is not sufficient. So Mini-CEX just एक patient encounter में जोड़ ली दूँ, and I am assessing him. That is not it. So it needs to be done at an interval, multiple times, multiple patients, and multiple assessors. So that is what will increase the validity of Mini-CEX. Some degree of differences between assessors are also there. Sometimes they may have some disagreement, and it does not represent the real world challenges like time constraint. We are trying to mimic the real life situation, but then consider that in real OPD he may not have time to examine a patient for 10 minutes. So it does not really mimic the world, but yes, it goes pretty much to a large extent there. So this was the form that I have given you, Mini-CEX exercise. It has mainly 3 parts. So the uppermost part is where you see the details of who the evaluator is, what's the date, whether the resident of, that means that you can either phase 1 student or phase 2 student. So what was the patient's problem? Which was the setting? Was it a OPD, ambulatory setting, inpatient setting, OT hatu, શું હતું, ક્યાં તમે કર્યું હતું? ED hatu, emergency department. What was the details about the patient? What was the complexity? So you can as well rate them. Okay, the department can decide that if it is a case of hernia or a simple case, then I will keep it at moderate. If it is a case of complex COPD, the patient has been coming for a few years or maybe 2 or 3 diseases, then I will keep it at higher complexity. Okay? The focus. So one Mini-CEX can have even one focus. Okay, so when you see those 6 skills, it is not humanly possible to assess each by observing a 10-minute encounter. Okay, so there are times when you may not have observed that I did not focus on the history data. I mainly focused on clinical reasoning. Okay, and history ne બધું બરોબર લઈ લીધું. But what was the clinical reasoning? એને પછીનું જે plan and management બરોબર કર્યું હતું કે નહીં, right? Or I was more focusing on counseling part, right? So what was the focus of this particular Mini-CEX that you are doing? So for each Mini-CEX there will be one form which needs to be filled. It needs to be filled in duplicate. One goes to with the student and one stays with you. This is the core part where medical interviewing skills, you can circle whichever is the score, physical exam, professionalism or humanistic qualities, clinical judgment. Now when you see physical exam, now physical exam also means that did the student respect the patient's modesty? Did he ensure that there was adequate privacy? Did he explain that આપણે હું તમને examine કરવા જઈ રહ્યો છું, એ બધું પણ એમાં જાય, right? When you see humanistic quality of professionalism, it means that did the student introduce himself? ભાઈ હું આ રીતે છું અને હું તમને આ 2 મિનિટ માટે, is it okay if I can talk with you, right? Also, જે રીતે એને વાત કરી, the way he talked with the student, was it compassionate? Was it worthy of being a doctor? Right? Clinical judgment is pure clinical knowledge, what he thinks the patient has. Counseling skills are mainly to ensure that the patient and the doctor are on the same wagon, so to say. This is what we are agreeing to do further, and so that is how what is counseling skill. Organization and efficiency, where another department is to be involved, or where the patient is to be sent to another department. Then did he think about that, would that department be open, or do I need to contact someone, and in order to ensure that this goes well, right? So organization is mainly how is he seeing the patient and how is that integrated into the overall practice of the hospital. And overall clinical competence is, the total one, the summation of it all. And I think this is what you want to see, that if I did not see for this, then I can strike this. So then I don't need to rate him for that one aspect. Okay. So finally, it is what was the time, observing time, which can be anywhere between 10 to 15 minutes. Feedback time can be 10 to 15 minutes. Evaluator satisfaction with the Mini-CEX. So this is not about satisfaction with the student, but with the overall experience of that Mini-CEX performance, right? Resident satisfaction, there are comments and both the signatures. Now, a few things. One is that this form has been translated into numerous languages, okay? But the core remains the same. This remains the same, okay? There are Mini-CEX forms where they ask the assessor to specify if he has given anybody 1, the rate of scale of 1 in any of this. That assessor has to specifically write why he thought that it was number 1. I mean, sort of so low, right? The same way, if he says that it is 8 or 9, then also he has to specify what he think was so extraordinary that he needed to give. So there are a lot of allowable, deviations possible even in Mini-CEX. Okay, so now this was about the clinical skills. This is about procedural skills. It is essentially the same. It stands for direct observation of procedural skill, same as Mini-CEX, but the trainees are performing procedures. Which are the procedures? Simple ones: injections, anti-tube insertion, venipuncture, peridural catheterizations, right? So for each skill, the steps can be predefined at the level of department. You can define that for a DOPS session of peridural catheterization, you just take this manual. It has all the details, like what all hardware you will require, where will the patient be. Secondly, what are the steps that you as a department expect the student to do, right? The skills that are assessed are understanding the indication and relevant anatomy, of course, consent, any procedure, consent skill, pre-procedure steps, whether he followed, if isolation or if there are any antiseptic techniques that was to be done, did he follow that or not? Aseptic technique, analgesia was given, post-procedure was the patient explained, follow, or if the dressing was to be applied, if the surrounding area was to be cleaned, did he do all of that? The rating scale is similar to Mini-CEX. So I think I have given you the form which has 2 sides. Okay, this is the first side, this is the second side. Similar thing, trainee name, assessor, designation, date, location, specialty, procedure complexity. There it was case complexity, here it can be procedure complexity, patient's details. Rating is similar, right? Unsatisfactory 1 through 3, 4 to 6 satisfactory, and 7 to 9 is superior and not observed. So, relevant anatomy, consent, pre-procedure preparation, awareness, aseptic technique, technical ability, the actual performance of the skill, seeks help if he thinks that he's trying to catheterize and he's not able, then he actually stops and then he tells someone, please come and help. Post-procedure management, communication skills and consideration for patient. So, patient needs to deal career, so that should always be there. And this is the overall procedure performance. DOPS form as well is, subject to whatever changes that the department thinks. Now, when we say that aseptic technique or technical ability or post-procedure management, these can be further defined for each skill. RT NG tube insertion તો એના માટે આટલા પોઈન્ટ્સ હોઈ શકે, catheterization માટે આટલા હોઈ શકે, venipuncture માટે આટલા હોઈ શકે. Now the second part is specific feedback by the assessor. This is to be written. Yes, ma'am.
So you are not observe.
Yes.
So why do you not do all these exercises when you are not observing?
Okay, so atla, see, these are the total points. Okay, so it is not possible that we will be able to see the student in 10 aspects. Yeah, for one particular thing.
Each point you are not observing.
Yes, yes. So whichever, consider that I did not check the aseptic technique for whatever reason, then I'll just say that not observed. And what will happen is, when the same procedure DOPS are done multiple times, the aggregate should have at least each one of this in this area, whether the patient, whether it was unsatisfactory or whatever. But consider he did 5 DOPS for RT insertion, then it cannot have any one aspect or attribute not observed in all of them. It cannot have. Every attribute has to be seen at least in one. This is the second part where there is any specific feedback by the assessor. It is feedback, so that is why it is a formative kind of assessment. Then trainee's comments. Trainee himself says what was his experience, or if he learned something new, or if he thinks that there were some lacunae. Areas of learning identified, a specific guidance is provided that maybe you should now learn this, or time taken for observation, time taken for feedback, and the signature. This is also done in 2 copies, one goes with the student, other with the assessor. So to summarize what I just said, you can assess a student and evaluate an educational program. Assess a student, evaluate. Traditional methods vastly lack validity and reliability. Workplace-based learning assesses the 4th level of Miller's pyramid. Okay, 4th level, which is action or does. And Mini-CEX or DOPS assess clinical and procedural skills respectively. Fifthly, they in a way provide structure, like these skills actually provide structure to what we already know. The same books are my references.